My name is Jen Aiken, and I am on the CoNSA subcommittee, education subcommittee, and we're very proud to present our second webinar for the year, and the subject of which is the role of ultrasound in continence practice. Where does it fit in, and where is it taking us? I'd like to do a little bit of housekeeping first. Would everyone mind making sure that their computers are on mute? We do have a process or a plan for the webinar. We've got our first speaker, who is Myra Teese from Zedu Ultrasound. We're going to follow that with Neil Connor from the Claris Ultrasound Probe, and then from Bonnie Geng, our nurse practitioner, who is going to talk to ultrasound in her experience with nursing practice, with her experience in that. But apparently Neil is on a plane, and so he may be a little late, so I'm just going to change things around a little bit. So I would like to hand over to, first of all, I'd like to do the bio and introduce Myra Teese. Myra began her healthcare career as a paramedic with Ambulance Victoria, where she quickly learned, often in challenging circumstances, the critical importance of communication, consent, respect, and compassion. And her journey eventually led her into the field of ultrasound, where she found new ways to apply her clinical experience, knowledge, and skills as a generalist stenographer. Now, with nearly 2 decades in healthcare, she has worn many hats: ALS paramedic, clinical instructor, paramedicine, tutor, stenographer, chief stenographer, and currently lead stenographer educator. Throughout her career, she has remained committed to delivering the highest standards of patient care, grounded in respect, compassion, and effective communication. She thrives on lateral thinking and problem solving, and she has a deep compassion for teaching and lifelong learning. When she has time outside of work, she enjoys time with family, playing with her children, snuggling with her cats, and trying to keep her wayward garden under control. So I'm very pleased to hand over to Myra for her presentation.
Right, thank you very much for having me. I'm just going to try to share my screen and see if that all works as seamlessly as it was working earlier. Hold, please. Now, why is that not working? Can you see my presentation? Or can you see? Ah, that's better. Hold again, getting there. You can see my presentation view, not my speaker view?
Yes.
Excellent. Okay, seamless, I told you. So thank you very much for having me to talk about POCUS for continence care. My name is Myra. I'm the lead ultrasound educator for Zedu Ultrasound Training Solutions in Greensborough here in Melbourne. And as we said, I have a very, very, very strong passion for making sure that we're seeing with sound in a way that is actually improving our patient journeys, making sure we're looking after our patients and keeping things as safe as possible. So what is POCUS? We keep using the word, but what is it? Point of care ultrasound, or POCUS, is the rapid, goal-directed and non-invasive tool that provides real-time insights that guide patient management without the delays of formal imaging. Whilst it is traditionally used by emergency physicians, GPs, and other healthcare providers to answer specific, immediate, and often binary clinical questions like, is there fluid in this abdomen, or is the heart beating? Continence care teams can also leverage POCUS to enhance their patient assessment, improve their patient comfort, and support more informed and timely decision-making. So the key advantages would be that it provides immediate answers to targeted clinical questions. It's safe, it's not invasive, it's patient-friendly, it's really, really well tolerated, and it can really enhance your clinical confidence and help guide your treatment and your referrals. So who uses POCUS? Well, if the internet's to be believed, everybody. Just jump on AliExpress and buy a probe, because that's kind of a real problem these days. And I think this is where the unease sets in for many, because while this is part of the reality, it just doesn't do POCUS justice at all. The vast majority of POCUS users are highly intelligent, highly skilled healthcare professionals that are really motivated. They want to look after their patients. And they tend to pick up the probe out of necessity for about 4 reasons. The first of those being that it might be the time-critical nature of their patients, so it's in the ED or the OR. It might be their isolated or remote geographical location just doesn't mean that they can reach the services that they need. In your cases, it's quite often that the answers to the questions or the procedures that you require aren't given to you by a standard radiology practice or by private radiology because they don't know what you need to know, and also they don't have a Medicare code to bill for it. So there's no monetary incentive. And then in this increasingly expensive world, a lot of healthcare providers are picking up the probe simply to increase their patient access to any form of imaging at all. It's really important that we recognise that these users are all motivated by a desire to improve their patient care, and that over time, there's been significant skill and expertise that have developed in the field of POCUS. In fact, I believe it's rapidly becoming a distinct stream of ultrasound in its own right. When I first started in ultrasound, I was told there was vascular ultrasound, and there was cardiac, and then there was general. But POCUS is becoming its own thing, and it should be respected, and it should be treated with care, with caution, and again, respect. So who really uses POCUS? Because it's not just those that buy a probe on AliExpress. It can be so many different individuals. It could be your emergency medicine physicians, your rheumatologists, your gastroenterologists, sports medicine specialists, pain medicine specialists, rehab physicians, anaesthetists, paramedics, continence care providers, CU, OBGYN midwife providers, aesthetics, plastics, physiotherapists, and this isn't an exhaustive list. The list goes on and on. If you can think of a part of the body you want to interrogate or look at the dynamics of, you can pretty much pick up a probe and have a crack these days. But we do need to find balance, and there are friction points, and we need to approach them with honesty and clarity. We know that POCUS can be really scary, and there are some healthcare providers and there are some radiologists out there who believe it's potentially dangerous. But this is often the thought with any new skill or procedure in healthcare and medicine. At one point in time, the stethoscope was considered complete woo-woo craziness until we learned how to use it and integrate it into our practice safely. There shouldn't be gatekeeping. Again, it needs to be about honesty, education, transparency, and then review to make sure that process is working. So I think the major concerns arise from the scope and diagnostic accuracy, because POCUS does give rapid targeted insights into continence care. It works best when you have a really clear clinical question in mind and you know what your limits are. Structured training and reflective practice will reduce the error and build your confidence. And please, if you're ever in doubt about your findings or it just doesn't match the patient in front of you, escalate, get a formal review, know your limits. And then there's issues around quality assurance and accountability. You need to have protocols, documentation, and feedback loops that ensure safe practice. So we need to support a culture of continuous learning, of audit, and of peer review. You need to know what's inside and outside of your scope of practice, and that's a critical notion for safe ultrasound provision. But we've got to call a spade a spade. It's a bit like Pandora's box. The horse has bolted, the tea has spilt, the ship has sailed. I could come up with more cliches, but we know that POCUS is out there. It's being used, so let's make sure we can steer this ship as safely as possible. So my focus today is how POCUS, when used in a safe, structured and systematic way and supported by ongoing high caliber education and training, it can be an absolute asset to continence care providers for real-time feedback, for patient education, for clinical decision-making, and ultimately improving your patient outcomes. So what is ultrasound? I keep saying the word. In fact, I've said it so many times, it's starting to sound a little bit strange in my head. We all know that it involves a handheld transducer, and they can look pretty different from purpose to purpose, and that we use that transducer or probe to create real-time images. Depending on what we're asking our ultrasound machine to do, or what mode we are employing, it can display different sets of information. So it could look a bit like our 2D or B mode images. So that's the black and white image that everyone thinks of when you mention ultrasound. Or we may use other modalities such as power or colour Doppler to assess for vascular flow or other fluid movement, like ureteric jets entering the bladder, for example. For your intents and purposes, these 3 modes are the ones that have utility for you where you are at the moment. We do also have M mode and spectral Doppler, but these are for answering pretty fancy questions about flow dynamics or movement over time, and they're pretty outside the scope of most continence care POCUS. So how is the image formed? And rest assured, I'm not going to bother you with physics or boring stuff. I know most of you are possibly in your postprandial haze after dinner, so I'll try to keep it relevant and interesting. because it's pretty fancy sonar. Our transducers or probes, they're sending out pulses of sound at an absolutely phenomenal rate, usually thousands of pulses per second. And they're also always listening. So they're kind of absolute masters of multitasking. And then it uses these sent out pulses of sound and the returned echoes to create a 2D image of a structure in real time. You could also think of it the same way as we think of a bat and the way it sees the world around it. So it's using echolocation. It sends out a pulse of sound, and depending upon what it encounters, echoes are returned back. The closer the reflector, the shorter that time will be. If it takes a long time for the sound to go in and come back, then the further the target is from the origin of the sound. So our probe is sending out these high frequency sound waves that bounce back or echo when they hit different tissues. And the machine will measure how fast or how strong those echoes are and turn them into a pixel on the screen. It is just really fancy echolocation. So my children like to joke that I'm like a big, gigantic vampire bat, and I sit in my little dark cave and I see all day with sound. My vampiric complexion and the fact that I hiss in bright sunlight probably doesn't help with that. So a strongly returned echo, such as from bone or dense tissues, will give you a white pixel. If the sound wave just travels through with no returned echo at a particular depth, in the case of fluid, which is a really great propagator of sound, and sound will just travel straight through that liquid, then we're going to get a black pixel. However, for all the shades of grey in between, that's just our different type of tissues. So let's apply that to a beam mode image. Looking at these images, we can see that a strongly returned echo is going to represent a bone or dense tissues. So that's going to be your white pixels. So in these images, if there was bone or spine or pubic symphysis, that would be a white pixel. And here we're getting the white pixels of the fascia around the bladder wall. When there's no returned echo at a particular depth, so in the case of the fluid, we get a black pixel. So in this instance, that's the urine inside the bladder. By then moving the probe, you can gain an understanding of structures in real time, like the bladder filling or the pelvic floor moving. But make no mistake, real-time 3D planar anatomy, it's really hard, and it doesn't come naturally to everyone. In fact, I struggled with it so much when I first started in ultrasound, and my anatomy and physiology, it was pretty good. We then also got our color and our power Doppler. Now, we're not going to go into these too much. They're used for assessing flow dynamics, but they are two very different tools. Though they look similar, they aren't the same, and we need to know which tool to use for the clinical question we're asking. Color, which is on the left, that's a pretty fancy tool that tells me about speed and direction of flow. Whereas the power Doppler on the right-hand side, this one is the better and more sensitive tool for almost all point of care questions because it's more of a binary, is there flow kind of tool. So think if I needed to find a ureteric jet, or if I needed to know if there was flow inside a mass in the bladder wall, this would be the more sensitive tool to employ. Now, if we consider X-ray, we all know that due to imaging conventions that govern the way the image is orientated, when I look at this picture, I know which way is up, which way is down, which way is patient's left, and which way is patient's right. So that when a patient is atypical, I know that it's the patient, and hopefully it's not the operator in an ideal world. Ultrasound is the same. It has conventions that govern the way the ultrasound image is orientated as well. So if we have a look at the top of this image, the green line represents the point of contact with the probe. So it's the superficial aspect. We then also got the blue area, which is the deeper aspect. So that's where our echoes are taking a long time to return from. We then have our probe marker side, which is the purple side, and our non-probe marker side. Now, when we have our ultrasound, the transducer is effectively cutting the object that we are scanning and looking at the slice that we're creating. So one of my colleagues, Simone, likes to liken it to looking at the face of a piece of bread that you've sliced. So in continence care, renal, pelvic ultrasound, it all comes under the banner of generalist imaging, unlike cardiac, which is completely different, but we're going to just back away from hearts for now. When your probe is placed in the short axis on your patient, your probe marker needs to point to your patient's right. So that means that probe marker side of your image is associated with your patient's right, the non-probe marker with your patient's left. If I was to rotate my probe into more of a longitudinal view or a sagittal view, my probe marker would now always go towards my patient's head so that my non-probe marker is pointing towards their feet. And these basics are absolutely critical when we're doing ultrasound to make sure that we are working within the convention, and that others can look at our image and know what we're doing. Now let's consider CT. Obviously, I'm just taking you on a tour of all the modalities. I would never look at a single slice of a CT scan and assume that I now have a decent 3D understanding of the anatomy that I'm assessing. I would need to get enough slices of the CT to see and build up a 3D map in my head as to what's happening with the structures inside the body. Ultrasound is the same, except it's a lot less forgiving because I have to move my hand and acquire all of those slices of anatomy. And I have to move my hand enough to see structures in their entirety. When we record images, and please make it a when, not an if, we need to record them in the same way that you're going to scan. And that's going to be with structure and with a system. Think of it as not just the evidence that justifies your course of action with your patient, but also like your handover to a colleague. For me, if somebody comes up to me in the ED and gives me this garbled handover that doesn't have a cohesive story, I'm unlikely to trust it, and I'm going to need to repeat that myself. So make sure that if you're recording images, record the same way you're going to scan, which is always going to be with a clinical question in mind, then with structure and with a system. So getting to the good bits for you guys, how can ultrasound help your patients? There are a lot of things that ultrasound can see that are incredibly relevant to your practice, whether that's bladder volumes, looking at micturition, whether you're looking at detrusor muscle thickness, assessing kidneys and ureters, urethra, prostate, rectum, fecal loading, catheter placement, bowel, pelvic floor, muscle activation, rectus diastasis. The list goes on and on. This is not an exhaustive list. POCUS can bridge the gap between symptoms and objective findings. So it's going to empower you as clinicians to improve your patient outcomes. So let's have a quick let's touch base with the idea that there are still formal ultrasound and point of care ultrasound, and they are separate. So your formal ultrasound provides your diagnostic gold standard when pathology is suspected, and it absolutely still has its place. It uses highly specialized equipment with superior resolution and a full range of modalities. Like I've got a lot of bells and whistles I can play with on my machines. It is essential for identifying underlying diseases beyond functional issues, and it forms the foundation for surgical or long-term planning, because sometimes I need the big picture and all the details you can give me. But point of care is immediate. It's bedside feedback to guide your care decisions based on the experience and the expertise of the user. You're often asking really specific questions for your care decisions. So it supports shared decision-making in real time. For example, you might realize the patient isn't fully emptying their bladder and that may need an adjustment in their plan. It is non-invasive, it is quick, it is repeatable, and it is useful for monitoring progress. So I liken it as sometimes you just need a specific puzzle piece as opposed to the whole puzzle for you to make a decision. It could also be thought of as that POCUS is kind of like your compass, but formal imaging, it's your full map. Both are incredibly valuable, but I wouldn't plan a complex journey without a map. So what do you need to consider when you're integrating ultrasound into your patient care? Well, you're going to need to think about the types of machines and make sure it can answer the clinical questions that you need it to. You're going to have to think about the cost of said machines. If you want to integrate this into your billing, there are incredibly complex rules around who can request, who can do it, where it can be done, and what you can look at. So make sure you understand how it may impact your billing. And then you're also going to need to ensure that you're doing it well. So you're going to need to commit to training and continuing education to ensure best evidence-based practice at all times. So the types of machine. So Susan and I were talking about some of the handhelds last time I saw her, or when we were on before this webinar started. Types of machines vary greatly. When I first started in ultrasound, there weren't anything like the amazing point of care machines that there are now. So you can buy these little handheld devices that hook up to your phone or to an iPad, and they're absolutely amazing for what they are. A step up from that would be your point of care carts or laptop-based machines. And then if we go up further from that, that's when you get your radiology carts, which are pretty whiz-bang, high-end machines. Now, when we're trying to decide which machine is right for us, it's important that we know that they each have their limitations. For somebody that doesn't like cars at all, I unfortunately use a lot of car analogies, so forgive me. I liken these to vehicles. So your point of care handheld, it's kind of like a golf cart. Yes, it can get you from A to B, but it has some pretty big limitations and it's a pretty simple apparatus. Your point of care carts and laptops, they're like an SUV. They're built for portability and durability and for ease of driving. But if I'm sitting in a radiology-based cart, that's a Formula One racing car. It has a lot of bells and whistles, and you really need to know how to drive it and what conditions are required to get the most out of it. So we need to understand the differences between these, the clinical questions that they can answer, and the resolution they can provide. So resolution refers to pretty much how clear your picture is or the detail it can provide. So a high resolution image is on the left, whereas our low resolution image is on the right. I was looking at this sheep earlier today and he just made me smile. So I hope he also makes you smile because he's just gorgeous. So when we're using our point of care machines, sometimes the resolution is not the same as some of the higher end machines. So sometimes it's about price point, sometimes it's just the literal reduced computing power or the limited acoustic output of the device that you're using. And other times it's about the simplified functionality. Often these machines are designed so that you're not afraid to use them. So they're oversimplified, so they're paint by numbers simple. But in doing that, you lose some of your advanced features or advanced tools. So if you are looking at some of the smaller point of care carts, laptops, or even a handheld for the ultimate portability, please, please, please try before you buy. They are not the same. They are not all intended to ask the same clinical questions. And where I work, we often get clinicians that have bought a particular, whether it's a handheld device or a point of care cart, and then they realize it's not actually designed to suit their needs and their clinical questions for their patient cohort. So what may be brilliant for a GP who's wanting to do some musculoskeletal ultrasound and a little bit of procedural work is going to be different to the settings and parameters that are required by the anaesthetist who wants to make sure the patient's heart is working effectively as a pump before they put them to sleep, or to the ED physician who wants to assess the shocked trauma patient. So there's also the simple fact that we just have preference sometimes with regards to the user interface. Why I may love my Android phone, you may be a diehard iPhone forever type, and that's just personal preference. So please, please, please try before you buy, because we see a lot of people who have buyer's remorse. So what should a training process look like? It should be structured, it should be systematic, it should be evidence-based coaching that keeps you and your patients safe. So is it see one, do one, teach one? Please, no. Ultrasound isn't a single skill that you can mimic after one demonstration, and yet it is still being taught this way, even in radiology in some instances, and that is absolute craziness to me. It is a complex set of cognitive and technical abilities that require deliberate, structured instruction. And when it's done poorly, the consequences aren't abstract. They affect real patients, and they compromise the safety and ongoing career, in some instances, of the clinician using POCUS. So the old see one, do one, teach one model comes from surgical apprenticeship, the surgical apprenticeship tradition, where the supervised repetition gradually built confidence. But ultrasound is so different. It is highly operator dependent, it is highly contextual, and it involves real-time image acquisition as well as interpretation. It is deceptively easy to hold a probe and get a fuzzy image, but it is dangerously easy to misinterpret what you're seeing. So if we rely on this old model, we're not building competence, we're creating overconfidence, which none of us want. I liken it to playing a game of tennis. So can you imagine going to the Australian Open, watching a match and then being like, okay, my Sora conquered, I'm going to do this now. And you walk out onto the court as if you can play. This is how I was taught, and it is insane. So we all know that this is a complex physical and practical skill, and we'd never attempt that in a game of tennis. It is a practical skill that requires deconstruction and deliberate practice. So you'd practice your forehand, you'd practice your backhand, you'd practice your serve. Hell, you'd even practice your ball toss before you wanted to play a match. And you'd practice each skill in isolation before you would expect to complete a decent rally. Ultrasound is exactly the same. It's a hands-on skill requiring structured step-by-step training to be safe and effective. And it also requires a coach that knows the moves and that understands the game. Otherwise, you're going to be learning through trial and error, and that's going to take a really, really long time. And again, I wish somebody had taught me this way, because it took me way longer than I'm comfortable with to get good at this. So ultrasound training should employ a hands-off teaching technique. When I first started my training in ultrasound, I didn't like it very much. Like you, I was an experienced and senior healthcare professional in my own right, and I did not enjoy quite literally having my hand held whilst trying to understand what on earth I was looking at. Instead of the instructor taking control of the probe and showing the learner the right picture, the educator should guide the learner verbally or visually while the learner is holding the probe. This allows the learner to directly experience the cause and effect relationship between the probe movement and the image on the screen. And by keeping the probe in the learner's hand, we foster muscle memory, spatial awareness, and problem solving. The learners develop the ability to troubleshoot, adjust, and interpret in real time, skills that are essential for safe and effective practice, especially in POCUS. I can't tell you how many times in my early ultrasound career I'd go off to a training day and I'd watch somebody scan and they made it look so easy. And then I'd get back to work and I couldn't recreate the magic. Unless the probe is in your hand when you're learning, you can't recreate the magic because you need the muscle memory to do so. So when you're holding the probe, we need to keep your patient's rights in the front of mind. So I like to think about, what does your patient need if you're performing ultrasound? When you're performing ultrasound, from the patient's perspective, they assume that if you're picking up the probe, that the ultrasound is performed by a well-trained clinician and that the findings are accurate and reliable. So this is why it's really important that ultrasound education is all about patient safety. Your patients have the right to informed consent. And by that, I mean that they know what POCUS is, they know why it's being done, and they know that its limits compared to a full diagnostic scan. There are times when if you've performed an ultrasound on the patient, they may forego a formal ultrasound because they think they've already had imaging done. So we need to make sure the patient understands the limits of a POCUS scan. They have the right to dignity and privacy. So we've got to ensure that there's minimal exposure, careful draping, and clear communication in sensitive contexts like bladder and pelvic scanning. Now, given what we're talking about today, I'm sure you're all across this anyways. They have the right to refuse or withdraw consent at any time. So they can decline or stop a scan at any time, regardless of where that probe is on the body and how vulnerable or not it may seem to the provider. They also need to understand that that is not going to affect their ongoing care from you. There needs to be accurate communication. So findings have to be explained honestly, with clarity and about the need for possible further imaging if required. And there has to be safety. Scans should only ever be performed within the provider's scope, with the images and the decisions documented in real time. And we have to have accountability and record keeping. Images, findings, and decisions should be documented clearly to support the continuity of care, to enable review, and to provide transparency. This is non-negotiable, it is critical, and it's the scary part for most of us when we start doing point-of-care ultrasound. So we've talked about what your patient needs, but what do you need? From the clinician's perspective, your safety will come from having a clear clinical question in mind every time you pick up the probe. It's not a magic wand. You need to know why you're employing it each time. You need to know the systematic approach for the exam that you're performing. You need the ability to understand normal versus abnormal appearances, even in a really binary way. So is it essentially remarkable or unremarkable? You need to recognize when you don't know what you're seeing and when it's outside your scope, and know when to escalate. And this is why ongoing ultrasound education and CPD to ensure evidence-based best practice will limit your risk and increase your patient safety. Because without structured education, providers can become unsafe without even realizing it. And that is a really dangerous place for you and your patient to be. So effective ultrasound education should look like expert-led instruction, a structured approach, systematic protocols, supervised hands-on practice, and then a deliberate progression. So you need to scan in a non-urgent setting or in a non-diagnostic setting just to learn the ropes. And then you'd be scanning patients under supervision, and then you'd move towards independent practice. Eventually, it may be worth considering assessment or credentialing, where competence might be demonstrated instead of assumed. And that's happening more and more in point-of-care ultrasound in different hospital departments. So one of my colleagues at CEDU, Sue-Ann, recently published a paper on deliberate practice in ultrasound, and she calls it the Goose method. And it's a really brilliant example of how, when we break down what can at first appear to be a really simple process, but is actually an incredibly complex process, when we divide it down into those bite-sized chunks, we can rapidly improve our learning journey. When I first started, my supervisor would sort of wave her hand over the abdomen with that magic wand, and then she'd magically choose a picture and tell me what was happening. And I had no idea how many steps she was going through to land where she did. So we've got Goose. Goose is get the window, optimize the view, optimize the image, select the image, and explain the findings. So this in reality looks like, where do you put your probe on the skin? How do you get the picture on the screen where you want it? How do you then change the knobs and the settings to get it optimized? How do you choose which image tells the right story? And then how do I explain the findings? So this is just one example of how task deconstruction can rapidly improve your journey. This is going to take time. If any of you are aware of the Dunning-Kruger curve, we know that we have our peak of Mount Stupid when we just get enough excitement and enough knowledge to get into trouble. There's the valley of despair where we realize how much we don't know. And then we eventually end up, hopefully, near the plateau of sustainability where we're getting that real experience backed up by expertise. So back to the good bits. We've got our white pixels, we've got our black pixels, and then we've got our seeing with sound. So what can you potentially assess? And in no order of difficulty or utility, there is so much that you can look at with time, with training, and with experience. And I'm sure you could come up with even more questions you'd love to ask. In the sonogram anatomy of the pelvis, we can look at all sorts of things, from looking at the bladder longitudinally, which is what I'm doing here. We might be looking at bladder contents, dynamics like ureteric jets or what's happening with micturition. We could be looking at the bladder wall. I might choose to do the same in transverse, which may allow me to look at the same list, or it may allow me to look at pelvic floor activation. If I was looking at a long male pelvis, I could look at anything from the bladder to the prostate. I might be even looking at the rectus abdominis muscles, the seminal vesicles, or the rectum. We can look at everything in 2 planes. And again, this is hard and takes time to get good at. So this is, again, that bladder and the prostate sitting behind. If I was to switch instead to a female pelvis, in the longitudinal view, I can see so much happening here. Do you know how long it took me to realize I could see the rectum in all of these pictures? So if I have the bladder, I have the vagina, the uterus, and the rectum, all in these pictures if I know how to drive this properly. So we can see so much for our patients. And we can see the same thing in transverse. In this image, what we're actually looking at is some pelvic floor activation around that vagina to see that pelvic sling moving. And we can also see, for extra points in the back there, we can see the rectum, where we may wish to look at rectal diameter because we know that that's having increasing utility for you in your practice. We may look at bladder volume. We may look at bladder wall thickness to figure out if that's part of our patient's issue. We may look for diverticulae. We may want to see the prostate size. And again, that rectal diameter, whether it's in pediatric patients or in adult patients, this is proving to be of increasing utility for us. Eventually, with enough time and training, you may even wish to go into the translabial pelvic floor. Please, please, please. This is a next level move and takes quite a lot of training to get good at. But we can see so much. We may wish to go to hydronephrosis because we may be wanting to have a look at if there's any back pressure issues with our patients, looking at whether it's screening for hydronephrosis, monitoring high post-void residuals, or seeing if there's an acute obstructive process occurring that's adding to our patient picture. There is a big difference, however, between image acquisition and image interpretation. I've had many a sonographer who could take me some damn pretty pictures, but without completing an assessment. I had one sonographer who'd take the most beautiful sequence of pictures of the liver, and he'd miss every single met in between. So make sure that you are taking the time to know what questions you're asking the anatomy to keep you and your patients safe. And again, it's going to need time. It takes time to train, it takes time to gain experience and to learn how this skill is going to integrate into your specific practice with your patients. So we know that this can improve and benefit your patients by immediate answers to clinical questions. It's going to add value across bladder, bowel, pelvic floor, kidneys. It's going to enhance your patient education, their buy-in and their engagement. It's going to give you answers to questions that radiology isn't answering for you, because we know that pelvic floor is not done well in radiology because there's no money in it yet. Sorry, but that's the reality. And it's going to guide referrals and patient management. So POCUS, honestly, it is the new stethoscope of medicine, and it's got so much utility in continence care. So long as we're aware of those pitfalls, so the focused scope, this is not a substitute for comprehensive. It's an adjunct. It is operator dependent, and the quality is going to vary depending on what you're using and your training and experience. There's going to be resolution limits. There's going to be patients that are just really hard to get all the information you need on. There's the risk of misinterpretation if we don't have a good structure and good training. Documentation gaps are a big issue when we have poor records. That's going to hinder follow-up and audit. And just again, remember, it's not an adjunct. Sorry, it is an adjunct. It is an adjunct. It is not a replacement. It supports your care and it doesn't replace formal studies. So in conclusion, POCUS is a powerful tool because it brings imaging to the bedside, right where your decisions are being made with your patients. And its true value lies not just in the technology, but in how we use it. So with systematic structured approach, we can harness POCUS to enhance patient dignity, support accurate decision-making and deliver more responsive, personalised continence care. And done well, it's not just safe, it's absolutely transformative. So thank you for your time. I know I talked really fast and that was a lot of information, but I hope it was helpful. I'm now going to attempt to stop sharing.
Thanks, Myra. That was absolutely fabulous, and I think you clarified a lot of information around use of ultrasound for nurses. In my experience, I work for New South Wales Health, and we're lucky if we have a bladder scanner. So we're quite limited. We've just come out of using that cartoon-facing looking scan. Where you've got the crosshairs and the yellow cartoon. Mm-hmm. Now we have ultrasound, and we've just got the bladder scanners. So we're quite lucky. But I can see the value of the knowledge to people in advanced practice and extension of practice in their private practice too. Thank you for that. We'll have some questions at the end. And if you don't mind, I do understand that Neil is now in the room, so to speak. Are you there, Neil?
Good evening, everyone. How are we? Thank you so much for letting me join your call. Sorry for the drama. I've just landed to sleepy Adelaide, where I live, and for some reason, flights coming in this evening were absolutely dreadful with timing. So, sorry, I'm sitting in my car looking like a disheveled mess. I'm sure my husband will disapprove when I get home, but it's so lovely to be here, guys. Thank you so much. I can give you some insight, team. I am a registered nurse. I currently work at Life Healthcare as the product marketing manager for regenerative medicine. We very recently became the Australia-New Zealand distributor of the Clarius handheld ultrasound, which it's awesome to follow on from Myra. Zadu are one of the premium providers of ultrasound education in Australia, so any content that Myra shared with you literally is gold standard textbook. When I was speaking to the team about coming to chat to you guys, continence for me takes me back to when I first started my nursing training, and I was with the district nursing team. And I think when I reflect, as we do as nurses, I got the district nursing sister really offside, because I quickly became the bypassing catheter guy who was sent out to every single call where some poor patient had, in essence, an issue with a catheter that wasn't functioning. So you could imagine in the UK, catheterizing male and females is what we do as registered nurses. I emigrated to Australia, was in operating theatres in Adelaide, and we had a patient came in who required a catheter. And I was like, oh, awesome, I can do the catheter. They're like, what do you mean? That's a woman. You couldn't possibly catheterize a woman. You're a man. I was like, uh-huh. I was like, I don't think that there's any ambiguity around my clinical competence. I was like, but if that's the world that we operate in South Australia, then I'll happily forsake my catheterization skills. So to this day, I must admit, I have had limited exposure as an anesthetic nurse now. I do one cheeky little shift every 4 weeks to keep my skill set up. And it's just nice to be that nurse in theatre that's like, yeah, like I've been around the block. Like, I like the fact that I now get to come here, hold hands and reassure patients that this big ugly face will be the first thing they see when they get to recovery. And hopefully it puts a smile on their face. So I've got a very short presentation, literally of 7 slides, to give you guys an insight into what ultrasound option we have at your disposal that makes affordability. Like, the primary driver is, we know there's no rebates. If you're working in a community setting or you're in a clinic environment, Clarius are excelling with artificial intelligence technology. And there's 2 specific things I'll show you. The primary one being bladder scanning. So in essence, when you use the Clarius ultrasound and you scan the abdomen, the AI technology identifies the bladder, measures the volume for you, and gives you an instant bladder volume reading literally in the space of 20 seconds. It means that there is no clinician to clinician error. Your skill set, in essence, is obviously the best point that we have for identifying anatomy, but we get that reliance to go, the AI technology is identifying the bladder margins and doing that measurement for us. So if I go to share my entire screen, maybe that's the way to go, and we'll bring up my tab. Sorry, team, the joys of Zoom, where we're now all users of Teams with Microsoft. It's taken me back to COVID times when we had to use a different format. Here we are. Let me know when you can see my screen. Okay, it says it's sharing. Oh. Any changes yet?
No, not yet, Neil.
Sorry, guys, I'm hotspotting to my mobile phone. So obviously Adelaide has terrible internet at the best of times, whereas now you're getting the joy added of a mobile phone hotspot. Says attempting to share. We've got the little wheel coming. Okay, here we are.
Yep, that's looking better.
Can you see? Awesome. And is it in full screen mode for you guys?
Yes, you just need to put it in full screen.
Perfect. So the joy is we've got it in full screen for me, but you're not getting to see that. So let me minimize this as much as possible.
Yep, that's good.
Okay, so in essence, Clarius, what does it look like for you guys? So the whole concept team is Clarius's Bluetooth-powered handheld ultrasound. So it's wireless, and the image that you scan, as Myra was alluding to, when you're identifying that anatomy, it either transports it directly to your mobile phone, so whether you've got an iPhone or an Android device, or to an iPad or a tablet. So it means that you've got that major function of usability that you can take from patient to patient without having to lug, whether it's a bladder scanner or another system on wheels. That portability and wirelessness is where we've seen the biggest response from clinicians that are not always in the clinic but community-based. The big driver of that artificial intelligence, to give you some insight, the TGA in Australia have been very cautious about us utilizing AI technology. And the benchmark with the US FDA is that we have to have 30,000 scans uploaded before Clarius can allow the AI technology to interpret the image that you see on screen. So it means that we can give that reassurance to patients that, hey, like, this is not just some newfangled witchcraft that we're alluding to you. Like, we can trust the data that it's giving us. The big key for me as a non-sonographer, non-ultrasound trained nurse is how it's ease of use. It's literally designed to enable you to function as an ultrasound with what you need it to deliver. But also it's got a massive scope, as Myra was alluding to, whether we're not just looking at bladder volumes or prostate measurement, if you are looking at bladder wall thickness or actually trying to identify abnormalities or ascertain, is there a clinical issue that's underlying? That skill that comes when you develop that knowledge, it means that you've got this device in your pocket that enables you to go on that journey. So the one device that we'll talk about is the C3 scanner. So in essence, this is an image of it here. It's the same height as the current iPhone. So it's about 11 centimeters. It weighs 300 grams. And the big issue is that it goes to a depth of 40 centimeters. So for us, if we're doing bladder scans or we're looking at prostate, whether it's male patients that we think have got BPH, which is potentially causing urinary retention, we know that this does more than what's required for what we need from our patients. The exciting bit, as I alluded to, is the AI technology and how we can back it up with marketing fluff that, yeah, it's trusted worldwide. They're made in Canada. It's a respected brand, but they've now got over 30,000 clinicians choosing Clarius every single day. Whether that's because it's affordability, that a scanner will cost you $7,500 and you can have it and use it, as opposed to buying a bladder scanner at 15 grand or whatever. We would err on the side of optimism and say people aren't buying it because it's cheap. They're buying it because they understand that Clarius are, in essence, a software company. They have made a really, really awesome quality ultrasound device for where it sits in its market, but they're looking to continually innovate in that space with technology. So currently over 70 countries are using it. The fact that TGA are giving acknowledgement of its AI capabilities, to give you guys some inference, like, it's huge. The fact that they have sat down and said, yep, we're willing to tick, big green tick, that we trust the AI performance of these devices. Now, the AI feature, I've got a really short video, which I hope will run for us. Because it's a link to YouTube, I've tried this twice and I think we still get the ad. So please note, whatever ad comes up on this YouTube video, I am not encouraging you to buy whatever product it is. So please disregard the content that's about to play. Deal. Let's see what the ad is. Oh.
Isn't it satisfying taking something that's been holding you back and just smashing it into a million pieces? Grow your business globally with instant business accounts and faster international payments. Air Wallets, the future of finance.
My name is Aiden.
Just so we know, I'm not in any way affiliated to Air Wallet, so we can disregard that entirely. There's no brown envelopes being delivered to my door. Can I just check, did we all hear the sound of that video?
Yes, we did.
Okay, so this is one of the pelvic floor physios who's going to demonstrate generally how easy it is to do a bladder volume measurement using the Clarius scanner. It's only 1.5 minutes long, but I think it's just good for you guys to see. It's like having a bladder scanner that you use every day, but also it has ultrasound capabilities for you to do more if required. So let's see.
Sim, and I'm a pelvic health physiotherapist. And today in this video, we're going to be looking at bladder volume measurements using the bladder AI function and the C3 scanner. So we're going to start with the application of using bladder volumes in physiotherapy clinical practice. And really, we can use this to measure post-void residuals, but we can also use this for clients who are coming in with urgency or overactive bladder and just helping them to reconceptualize their bladder volumes. So we're going to start with our client in a crook lie position. So we're going to use the voice control today. So I'm going to unfreeze the image. We're going to place the probe with the marker to the patient's left. And we're going to get a clear image of the bladder so that we can see all 4 sides of the bladder here. We're also going to use the bladder AI function. So that brings up that there. And getting a clear image here, we're going to freeze the image. I'm going to adjust the calipers slightly here. And then we're going to capture image. Then we're going to rotate the probe sagittally so that the marker is up towards the client's head. We're going to unfreeze the image. And again, we're going to freeze. And we're going to capture image. And then you're going to see the bladder volume in the top left corner of the screen there. And that wraps up bladder volume measurements.
Now, I joke, guys, and it's easy to be so flippant that was really straightforward and easy, but I genuinely say that is what it looks like in clinical practice. Taking the scanner out your pocket, placing it over the patient's abdomen, the AI technology identifies the bladder right there in front of you. Sadly, it makes it that horrible sputum bile green color. Why we couldn't have had a nice, more pleasing color to look at is beyond me. But the joy is It's about enhancing your capability and giving you that reassurance that, as Myra said, my skill might not be awesome. I'm not sonography trained. I see images in practice. I know what I'm looking at, I think, but it just revalidates the fact that the AI technology will identify that border for you and give you that measurement within 35 seconds. So whether you have got those patients that you're seeing in the community, or there's a fight over who's got the bladder scanner, there's only one available, it's up on the ward, we can't find it, for an investment around about that $7,500 mark, it means that in essence everyone can have one charging in their room or in the clinic base. So bladder scanning is fantastic, that's awesome. What happened is in the US, they understood that the amount of male patients that have got BPH, and that was leading on to, is their prostate also contributing to the fact that we've got issues with urinary retention? They created another aspect of prostate AI. So in the exact same way as bladder AI, the same scanner does the exact thing. So this again is a minute video. You'll see this time they've chosen a nice blue color to highlight where the prostate is. But if we show this little video, you'll see exactly what I mean. Again, full disclosure, I don't know what ad is coming, so please forgive me if it's something related to in my sweet tooth at this time at night looking for chocolate. So I apologize if it brings on a craving.
Build a website you love with Wix, where your words create your brand.
I'm Janae, and I'd like to tell you about Prostate AI. This feature allows an ultrasound user to quickly and easily identify the prostate, measure its volume, and corresponding PSA density. I'll demonstrate that now. We'll start at the patient demographics page, and this is where we would enter the patient's name, birth date, and any other relevant medical information. When we scroll down, we can see there's an area here to enter the patient's PSA levels. I'll enter 3 for the purpose of today's exam. Under the indications header, we can see some areas where we can fill in for indications for the prostate exam. We'll come back to this page at the end of our scan. I'll tap the scan button, and I've selected the C3 scanner for today's scan, but just take note that the Prostate AI is also available with the EC7 endocavity scanner. Under the Applications tab, I'm going to select the prostate preset, and we'll begin our scan. I'm going to start in a transverse orientation over top of the patient's pelvis, and I'll angle downward towards the patient's pubic bone. To activate the AI, I'll select the AI icon on the left-hand side of the screen and select prostate volume. The transverse label has been applied to the screen for me, and the prostate has been highlighted with a masking overlay. I can adjust the opacity of the masking overlay by selecting the AI teardrop icon and selecting AI opacity. And now when I drag my finger on the screen to the right, the opacity of the masking is increased, and to the left, the opacity is decreased. When I'm happy with the look of my image, I'll select the freeze button and the calipers that have been placed for me. I can adjust the caliper placement by dragging my finger over the crosshairs and placing them into a position that I like. I'll tap the camera icon on the bottom right-hand side of the screen to save my measurements and image. We'll tap the unfreeze button, and I'll rotate my scanner 90 degrees into the sagittal orientation. The sagittal label has been placed for me, and when I select the freeze button, the caliper is automatically placed. And on the top left-hand side of the screen here, we can see all 3 of those measurements along with the prostate volume has been calculated on the screen. And now when I save this image, those measurements are transferred to the Clarius cloud. We'll tap the back arrow and head back to the patient demographics page. And here we can review our images, our measurements, and any of the calculations. We can also see here that the PSA density has been calculated for us. We'll scroll down to the impressions heading, and here we can enter any findings from our scan. We can tap the end exam button, and we've completed our prostate study.
So there we are, guys. So that's just a quick demonstration of what the AI technology does for the bladder and for the prostate. I think the key thing for me is just thinking about if we are, and again, it's a really cheesy marketing slogan, but again, listening to Myra's points, like, we are all learning as clinicians every single day, and our confidence grows as we learn. But more importantly, it grows when we get more experience and exposure. Like, no one's expecting us to be first-class skilled sonographers straight out the bat. But as long as we have got the capability to have software that takes us on a journey that in essence is just focused on improving patient outcomes, that's why we're happy that Clarius are offering this technology for us. So we've got the stream about you being a novice, moving on to being an intermediate user, whether that's supported with doing additional training with organizations like Zedu. For our perspective, if we got to being advanced clinicians and that became a part of that patient assessment tool where as nurse specialists, we actually were interpreting ultrasounds, potentially diagnosing patient outcomes, it's the journey that we all potentially could be on. We don't know what the future holds. So my last slide in wrapping up is just saying that Clarius Classroom is where it all stems back to, that teaching portal. Like, we have a classroom online that when you type in any indication, if we type in women's health, pelvic floor assessment, urinary retention, there's over 500 videos currently stored of clinicians doing exact patient assessments live in real time for you to watch, pick up some hints and tips and learn from as you go on. So the last thing for me to say is the Clarius membership comes with the pricing. So that software, in essence, if you buy a Clarius scanner as it is on its own, it's $4,670. That means that you can scan and look and do what you see on the screen. The software that has the AI technology comes as this membership package. So either 3 years of it is $2,700 or one-time license, which means it lasts forever, is $4,000. If you guys are keen to have a play with the Clarius, myself or one of the other nurses in the team would love to come along, have a chat with you, bring it into your clinical practice, let you put it in your hands and see if it actually does what my lovely presentation tells you. But I'm just excited, guys, that we're now at a stage where we have an affordable solution at our disposal that literally is giving us a new set of skills and capabilities that is just shifting away from reading a measurement on a bladder scanner. Like, the scope for us to improve our skill set is absolutely huge. So yeah, thank you very much for allowing me to talk at you in my hoarse voice and my sleepy face, but I'm here to have any questions when we get to the end of the session. So thank you so much, guys.
Thank you, Neil. Very much, and thanks for the diligence of hopping out of that plane and into the car and onto the computer. I'll move straight into our next speaker because we're running tight for time. I'd like to introduce Bonnie Young. Bonnie is a nurse practitioner. Bonnie is comes with a specialised focus in functional urology and pelvic health. She has over a decade of nursing experience and postgraduate qualifications, including a Master of Nursing Practitioner, hooray Bonnie, and a Graduate Certificate of Stoma Therapy. Bonnie brings a comprehensive clinical skill set to her advanced practice role. And she has developed significant expertise in diagnostic modalities with a strong emphasis on ultrasound applications. She's skilled in performing and interpreting urodynamic studies, uroflowmetry, post-void residual bladder ultrasounds, and has completed advanced training in pelvic floor ultrasound through Concord Urodynamics and Pelvic Floor Ultrasound course. Her diagnostic acumen supports effective patient care planning in continence management. She currently practices with Sydney Urology Associates, where she collaborates closely with a urologist, Dr. Amanda Chung, in both diagnostic and interventional procedures. She remains committed to integrating evidence-based practice with advanced clinical skills to optimise patient outcomes in urological care. Bonnie is going to give us some insights into her experience with ultrasound. You there, Bonnie?
Yes, I'm here. Good evening, everyone, and thanks again for that lovely introduction. Way to put me at the spot, but thank you. So I'm also a little bit wary about the time. I don't want to keep anyone here for too long, and understanding some of us are just finishing work and staying back for this webinar. So I'm going to keep this presentation nice and short. But first of all, let me figure out how to share my presentation. Oh, hold on, that didn't work. Share. Okay, can everyone see the slides?
Yes.
Yep, okay, fantastic. All right, so yes, yeah, any problem with the slide?
No, that's great, Bonnie.
Okay, wonderful. So my name is Bonnie. I've been working in urology in the last 10 years. And for the last 6 years, I've been focusing on functional urology, and that's where my specialty is. And I also do a lot with urinary implants, AUS, artificial urinary sphincter, or inflatable implantable device like IPPs, so inflatable penile prosthesis, and etc. And I also do a lot of functional work, which requires me to perform urodynamic study with the use of an ultrasound in the private setting. So today I have the honors to talk about ultrasound use in continence. I did put quite a lot of slides in this PowerPoint, but I think I'm gonna skip over quite a lot of them. So again, ultrasound, as a lot of you already know, the reason why we use ultrasound in urology is one, to measure post-op residual urinary retention assessment. And in my practice in particular, it also helps me to differentiate whether or not the patient is experiencing incomplete bladder emptying or whether or not the problem is to do more with the overactive bladder. Because what we know is some of the symptoms that these two problems presented could be quite similar. So the patient can be experiencing urinary urgency, frequency, and also having small voided volume. And also helps us to investigate whether, sorry, that was a little bit too fast, whether or not the patient is incontinence is related to overfilling of the bladder. So, yeah, and then like I mentioned before, we also use ultrasound in urodynamic study. The reason why we use ultrasound is so that after we fill the bladder up, we can assess the outline of the bladder to have a look at the anatomy. I found it really useful in terms of doing the assessments on patient with stress urinary incontinence, which I do have some pictures and slides later on. I will further explain that. And post-operative monitoring, try to avoid, of course, and also for the neurological patient, with the patient with neurological condition. So such as anyone with spinal cord injury, as we know, when the bladder gets overly distended, they are more that lead to the risk of autonomic dysplasia. So using the ultrasound regularly will help us to monitor the volume, the bladder volume. And also for patient that performs clean self-intermittent catheterizations, it's also important to do the ultrasound at when we first training them to do the CISC and making sure they actually performing the correct technique and emptying the bladder efficiently. And as you know, if they're not able to empty out the bladder completely, then the leftover urine is likely to then they're more prone to having problems with recurrent UTIs and also with the bladder stone formation due to the incomplete bladder emptying and the stale urine be sitting inside of the bladder for too long. So clinical benefits, of course, is ultrasound is non-invasive, it's patient-friendly, and it also helps us to provide a more accurate assessment and helps us to guide the safe management of whether or not the patient is experiencing, whether or not the presenting symptom is to do with retention or incontinence. So it helps me to formulate my management plan. And it also has a low infection risk because it prevents unnecessary catheterizations, and it also helps to save healthcare costs as well. So like I said, I'm just going to jump through all of that. So in personal practice, on my day-to-day practice, I do utilize ultrasound imaging to perform flow tests and post-void residual scans. So that helps me to look at the post-void volume, that's for one, and it also helps me to assess the bladder anatomy to see whether or not there's any intravesical prostate protrusion, for instance, or any diverticulum. So, and yes, urodynamic study. Traditionally, urodynamic study has been done under fluoroscopy, but in a more recent time, it has been performed under with ultrasound, I should say. And the reason of that becoming why ultrasound use in urodynamic is becoming more and more popular is to do with, well, one is minimal risk involved, no radiation exposure, and two is it increases the accessibility of service. So rather than having to be on the waiting list in the hospital or radiology, you can have the urodynamic done in the right setting in the community or in the private practice. And ultrasound also helps me to investigate or troubleshoot with my post-implant patient. For instance, if any patients that has artificial urinary sphincter put in but is experiencing urinary incontinence, when I invite them to come back for a review, I will always perform a flow test, post-void residual scans first to make sure they are emptying the bladder efficiently. So the incontinence is not to do with overfill incontinence. Second of all, I would also like to have a look at the device reservoir that's sitting at the lower part of the abdomen to make sure the reservoir is inflated and full. All right. There you go. So apologize, some of these pictures I actually had to borrow online because I don't have that many pictures in my own data. So this is one of the pictures that I got from online, and you can see in the image that is a bell-shaped bladder. So the bladder neck itself is descended downward. This is a case of a lady with cystocele experiencing stress urinary incontinence. So, and as a lot of you may already know, the normal anatomy for the bladder should be within this yellow circle. But because of the pelvic floor deficits, therefore you see this bladder has become in this bell-shaped structure showing in the film. Okay, so jumping through. Okay, so case study. I thought giving you guys a couple of case studies will help you understand a bit more on how I employed ultrasound image in my daily practice. So first case study, Mr. Jones, 67 years old, with history of BPH, urinary hesitancy, slow stream, and also feeling of incomplete bladder emptying. He does have some urinary frequency and nocturia, and with history of recurrent UTI as well. So we have performed a urodynamic study to just have a look at the bladder function. So during the urodynamic study, what we found was he has a high diffuser pressure associated with a low flow rate, and which is consistent to a bladder outlet obstruction. When we were performing the ultrasound, the ultrasound showed a bladder wall trabeculation, meaning the thickening and also roughening of the bladder wall. And also a large bladder diverticulum. So that's the outpouching of the bladder wall. So again, apologize. This is another image that I have borrowed from the online library. But in this image, you can see a very big and full bladder on the top. And then underneath it, it has almost the same size outpouch. So that is the bladder neck. So that is the bladder diverticulum. And then you can also see the connection between the bladder and the diverticulum. So that's the neck. All right. So yes, we talked about neuropathic bladder just a little bit before. So the next case is to do with a young lady, 53 years old, with history of multiple sclerosis. She presented with some urinary urgency, urinary incontinence, but not associated with cough or laugh or abdominal straining. And she does feel incomplete bladder emptying and has a history of recurrent UTI as well. So the first thing what I did when I saw her was I performed a pre-void and also a post-void bladder ultrasound, which showed that she was holding back on 640 mils residual in her bladder. So And on further discussion, she would like to try and monitor and manage her incontinence conservatively. So I do suspect her incontinence, because it doesn't sound like there is a little bit of urgency there, but it's not too troublesome, and it doesn't sound like her incontinence is to do with is stress related. So it's likely to do with overflow incontinence due to the high PVR. So we have decided to trial CISC and on the regular schedule and come back for review. And if that doesn't alleviate her problem, then we will proceed to a urodynamics dynamic study. This is another unrelated film, but I'd probably, yeah, anyways, I'm going to show it to you guys here. So another reason why using an ultrasound is good in terms of helping patient that has a catheter is like you see in this film. So this patient has a bladder diverticulum. So after the catheter was inserted, the clinician actually noticed there's minimal output in the catheter. However, there's no bloods, but the patient was experiencing increased bladder distension and bladder fullness and increasing urgency. So a bladder ultrasound review that was conducted revealed a full bladder. As you can see in here, that's the bladder lumen filled with urine. And you can also see the catheter, the body of the catheter inside of the lumen. However, the balloon of the catheter, it seems to be, on the first glance, seems to be on outside of the bladder, but it doesn't sound, a protrusion just doesn't sound right, because there's no blood in the urine, and also the patient is not complaining of pain, and he's clinically stable. So by using the ultrasound, we know that the catheter is actually being misplaced. The clinician was able to withdraw the catheter back into where it's supposed to be, and inflate the balloon in the right, correct position. And as you can see here, that is the bladder diverticulum. So the catheter was actually being inflated inside of the blood, in the bladder diverticulum. Okay. Okie dokes. And this is a recent case that I have seen in my clinic. So I thought it's interesting to discuss. So I have an 86 years old gentleman who had a radical prostatectomy and also radiotherapy in the past. This gentleman had a mild advanced XP sling put in about 8 or 10 years ago, and he came to the clinic with concerns of urinary urgency, persistent stress urinary incontinence, and urine leakage when standing up from a chair. So we have performed a urodynamic, thinking that, okay, there's urgency involved and there's stress urinary incontinence, but what is causing this? What is the predominant factor that's contributing to his current incontinence? Is it an overactive bladder, or is it a worsening of stress urinary incontinence? So the urodynamic that was performed has reviewed a mild detrusor overactivity, and we have seen urine leakage, urinary incontinence, which associate with a low leak point detrusor pressure, about less than 20, as I record. So I wasn't convinced that the detrusor overactivity, with such a mild detrusor overactivity, I wasn't convinced that was the main contributor to the incontinence. So what I did was I proceeded to do a transperineal ultrasound, which is shown in this picture over here. So that's the bladder itself, and the urethra is actually this part. And where my arrow is pointing, this white little dash here, that is the sling. And I apologize, I don't have a video, but when I performed the ultrasound, what I asked the patients to do is to cough and to bear down. And through that motion, what you can see, what I could see, was the bladder descent downward. Remember, the pictures is actually inverted. And then with that motion, normally in a functional sling, what it's supposed to do is, with that downward motion, is supposed to, the sling's supposed to create a kink in the urethra. That's how it stops the urine from leaking out during abdominal stress. However, in his case, when he was coughing and bearing down, I do not see any movement or closure in the urethra. therefore, my diagnosis for that was due to the patent urethra on abdominal straining and coughing. So the urinary incontinence, or the increased urinary incontinence that he experienced, is actually to do with the low outlet resistance on the stress test, despite the stent, the sling in situ. Yep, and then there's a couple more pictures. So with artificial urinary sphincter, remember we talked about the reservoir. So this is a video I recorded today, actually. So this patient came in and saw me because of urinary incontinence and increased urinary frequency after having the artificial urinary sphincter activated. So the first things I do is we do a flow test and post-wall residual scans and making sure they are emptying the bladder properly. And also we check whether or not the reservoir itself, which is this little bubble, is inflated. It looks nice and round, and it's got about 10 mils of fluids in there, 8 to 10 mils. So this is the normal volume. I was quite happy about. So it turns out when he was using the artificial urinary sphincter to urinate, he's actually not been able to hold on to the pump properly and to effectively squeeze the pump. Although he can see some urine coming out, and whenever urine stops, he thinks he's finished. But in the post-wall residual scan, what we can see is he's actually still holding back some urine there, so which contributes to his urinary frequency and overflowing incontinence. Okay, yeah, and then another study. Oh, almost done. And then another case is which will show how I utilize ultrasound is managing post-op wound complications. So I have this lady had SPC inserted, and then 2 weeks post-ops, she called in to the clinic quite concerned about leakage coming out from the SPC stoma site, and also reported quite a lot of swelling in the abdomen. And I have invited her to come into the clinic and have a review. And thankfully, the catheter itself is actually draining really well. The urine is looking clear. There is a noticeable swelling on the superior aspect of the SPC insertion site. And there seems to be quite a lot of yellowish, but to me that looks more seriously, hemoseriously type of fluids coming out from the SPC site. So I have proceeded to do an ultrasound on top, above of the SPC insertion site, and then which reveals a seroma. This is just a random picture of a seroma I can find online. So as you can see, this dark fluid is the seroma. So I was able to put her on antibiotic and also to monitor her on every, I think initially we were monitoring her every week and then every 2 weeks until the seroma subsides. She's a very nice lady, but she's also very anxious. But having the ultrasound technology was able to help me, one, to perform my assessment, and two, also to show the patient so what is actually happening. That provided her with quite a lot of reassurance about my follow-up. So yes, that is my somewhat of a short presentation, and this is my contact detail. If anybody would like to reach out with more questions, I'm always happy to answer to the best of my capability. And then here is a list of my reference. So thank you so much for listening.
Thanks, Bonnie.
No,
that was a fabulous presentation and very.
I'm so sorry. I'm actually quite nervous. So I'm not a very good public speaker. So I hope I did a good job.
No, that's great. It was really meeting the brief really well. It gave a really good demonstration of the use of ultrasound in your practice and what you actually find. And yeah, that was good. Yes. We are a little bit over time, but I do think that we could probably do a question each if people don't mind hanging around. I do have a question for you, Bonnie, to start with.
Yep. Okay.
How do you differentiate between overactive bladder and urinary retention using the ultrasound? And the second question of that is, which ultrasound machine do you use?
Yeah. Sorry, I'm trying to, am I still sharing my screen at the moment?
Yep.
Or
Yep.
I am? Am I still at the page of the presentation?
You're at references.
References, okay. Sorry, I'm not very tech savvy. Okay, well, that's all right. I can't really figure out how to. Oh, hold on. So I'm back at sharing now, am I?
Yeah, stop sharing.
Okay. All right, let's just do that. That's much easier.
Great.
Yeah.
So the question was, how do you differentiate between overactive bladder and urinary retention using sound, and which machine do you use?
Okay, so at my clinic, we have the point of care, the chart, ultrasound, not the chart, ultrasound card. And with that, backtrack a little bit to answer the questions. How do I differentiate whether or not the patient has urinary retentions or overactive bladder? You will do by performing an ultrasound, you know how full the bladder is post-void. If post-void residuals is more than 200, 300, then you will know there's definitely a retention. And when we think about bladder capacity, what we know is by the time when the bladder reaches 500, the person is really wanting to wee. Correct. And that's the normal bladder capacity, maximum capacity. And when you only empty in about 200, leaving around 300, then it doesn't leave you that much space to fill up. So only have 200 capacity for it to fill. So a lot of time the patient will have increasing frequency. They need to go to the toilet more often to try and empty it out. But overactive bladder, on the other hand, is to do with the bladder the detrusor instability. So it doesn't always, I should not really wording this correctly. Just bear with me 1 second. Yeah, so it doesn't always to do with a large volume, but as little as for some of my patients, even 50 mils of urine, the bladder will start to not like it and start to spasm and forces the urine out and causes incontinence. So overactive bladder incontinence and also overflow incontinence is quite different. But using the ultrasound will be able to give me a clear picture in terms of, okay, are they actually emptying out properly? So is there any underactivity involved with it? Or, yeah, it helps me to form a more clearer clinical picture. Is that clear, or am I just making things more complicated?
No. I think that's clear. I think that's answered the question. And to the second part, what ultrasound machine do you use?
So I use the to Maya's slides. I actually use the Ferrari version. That's the fortunate part of working in the private practice. Yeah. So we do have a lot of good equipment, but when I actually attended the NCOI conference in Hobart, I had the pleasures to learn from the other portable version with the iPad. That was fantastic. To me, the resolution was really clear. And if in the future, if I have the privilege to take my service into a more of a community base or have a mobile service, that will be a very great investment for me.
Yeah, I see the benefit to that.
Yeah, but it depending on what kind of scope of practice and how big of a how would you like to run your service.
Yeah. Thank you, Bonnie. That's great.
Worries. Thank you.
I'm wondering if anyone has a question for Myra. I have a question for Myra. Are you there, Myra?
Yes, shoot.
Oh, hi. I mentioned earlier I have the New South Wales Health version of a bladder scanner, which we have upgraded to ultrasound ability, but it's still just a bladder scanner. Can I use that to investigate constipation, pelvic floor muscle movement? Can I use my bladder scanner for that if it's an ultrasonic one?
That's a really good question, and it would really depend upon exactly which one you have, but usually they are very limited because they use the software that they use looks at the bladder volume by detecting the potential space. So my understanding would be no, but I'm happy to be corrected by somebody else. Usually, if I want to be able to do any measurements or have a look at fecal loading, that requires a different sort of machine because, the bladder scanners are, the software works differently to your standard sonography machine.
Okay, right. Thank you.
Unfortunately, sorry. But I'm happy for you to, if you want to send me through a picture of it, I'm more than happy to have a look and tell you what it is capable of.
I can, because it's quite a good scanner, but I do suspect, and I do suspect you can see other things on that. But I don't know that I've actually I don't have the training to do that. So I think
I'm going to pop my email in the chat if you want to just grab that. If anybody has any questions that they think of, because I know sometimes, I'm not scary, but it can be hard to ask in this sort of forum. If anybody has any questions, just shoot me an email.
I really appreciate, I think it's been a great webinar today. I appreciate you setting up, ultrasound, what is ultrasound and how to work it and what sort of findings you can have, and also Bonnie talking about how she actually uses it, and Neil in the middle. So I think that's really good. Yes, so any other questions we'll direct to you through email if we get them. I'd like to close the webinar, but I do want to acknowledge that because it was a bit of a clunky start, that I wanted to acknowledge that I didn't do the acknowledgement to country, and I apologise for that. But I just wanted to say that we, CoNSA, acknowledge the traditional owners of the country throughout Australia and acknowledge their continuing connection to land, waters and community. And we pay our respects to the people and the cultures and the elders, past and present. I've done it at the end, not at the beginning. I think that's okay. Myra, thank you very much.
Thanks,
Bonnie,
Myra.
thank you.
Thanks, Bonnie. Thanks,
and
Neil.
I think Neil has left the building.
Thank you so much for inviting me, guys.
Thanks, Bonnie.
Yeah. All right. See you guys.
Bye.
Have a good evening.
Bye.